Good day. Today we will present a case study entitled, Glansman, I Can't Bind Without You.
The case is about a 6-year-old boy having repeated nosebleeds and a tendency to bruise. This concerned his aunt, a clinical laboratory scientist. She examined a blood film made from a capillary skin puncture sample and noted that the platelet count appeared normal, but that, contrary to the expectation with the capillary puncture sample, his platelets were not clumped on the blood film. She persuaded her sister to take the boy to a physician. The patient's CBC was normal, but his bleeding time exceeded 15 minutes. The PT, PTT, thrombin time, and fibrinogen assay were all normal. Platelet aggregation studies revealed a total lack of response to ADP, a partial response to collagen, and a normal response to ristocetin. The first question regarding this case is, what is a likely cause for the patient's bleeding history, and what are laboratory tests might be helpful? The child is possibly suffering from a condition known as Glansman thrombasthenia, an inherited autosomal recessive genetic trait. That means both of your parents must carry the defective gene or genes for Glansman's in order for you to inherit the disease. This condition typically presents as excessive bleeding and easy bruising on the affected individual. The platelet aggregation studies are abnormal with agonists such as ADP, collagen, or epinephrine. Platelets are not able to clump together when stimulated. On the other hand, it shows a normal response to ristocetin. Also, bleeding time is prolonged due to the defective receptor, which is essential to blood coagulation. Other tests that may be helpful in the proper diagnosis of the condition are platelet function analyzer 100 study, flow cytometry, and monoclonal antibodies. On platelet function analyzer 100 study, testing in patients with Glansman thrombasthenia, the platelets fail to plug the collagen-based filter. Flow cytometry tests the platelets' binding activity to the antibodies that recognize the glycoproteins 2B and 3A. It will quantify and measure distinct platelet receptor densities using varieties of monoclonal antibodies directed against the glycoproteins. In this test, the said glycoproteins are diminished or absent. Both flow cytometry and monoclonal antibodies confirm the diagnosis of Glansman thrombasthenia. The second question regarding this case is, what is the basic defect in this condition? Given that the condition of the patient is Glansman thrombasthenia, the basic defect is an abnormality or deficiency of the membrane glycoprotein 2B3A, encoded by ITGA2B and ITGB3 on chromosome 17. The membrane receptor GP2B3A is capable of binding fibrinogen, von Willebrand factor, fibronectin, and other adhesive ligands. The deficiency or abnormality in the membrane receptors causes failure of binding of fibrinogen, thus, platelet aggregation does not take place. Hence, there is no hemostatic plug formation that leads to serious bleeding characteristic of thrombasthenia. The last question regarding this case is about what information was obtained by the original capillary puncture blood film. The picture at the top presents the blood film obtained from capillary puncture of the patient with normal platelet count and no clumping. The picture at the bottom shows a blood film obtained from a capillary puncture which shows platelet clumping. This should be observed because an anticoagulant was not used. This suggests that platelet aggregation did not take place, which is usually observed in patients with Glansman thrombasthenia. The information obtained was gathered from the following references.
Here are the members of Group 1. Christine Joy De Leon, Therese Bianca Flores, Vanessa Julia Gamboa, Maria Agnes Teresa Que, Tony May Kimbao, and Sofia Beatriz Sarmiento. That's all. Thank you.